We developed TUNET, first of all, for local applications. When I started, it was 10 hospitals in 8 countries. So HUNET was a very small project when I started. So it's to promote local use for local applications. And secondly, to promote national and international collaborations. The local is more important because for 2 reasons. One is at the local level, where you have the infected patients and the hygiene issues and the policy issues. You need to treat these patients locally. The other reason the local is so important is if there's no value to the local data generators, it is not going to survive for national and global surveillance. So to have a global system, there has to be some value to the laboratories and the institutions that generate the data. Since I've been involved in surveillance of resistance, I think we have really made a lot of improvement in the quality of data, of laboratory data, knowledge and interpretation of those data, but we are still faulting on using those data to support interventions. One of the good things in the last 20 years is the growing recognition and involvement of national health authorities in data collection, in data analysis, and in data use. You see that in the 2010s World Health Day, the UK AMR review under Lord Jim O'Neill. The AMR review was about the cost of inaction. The World Bank report was about the cost of action. What does it take to do these interventions? So there's a much more holistic sense of bringing together all of the different sectors on the data collection side, but also on the data use side, the media, educators, researchers, industry, patient advocacy groups. For me, it comes down to we've done a good job, a very good job of improving our ability to capture and standardize and understand data. What is still missing in many countries, some are much more advanced, others further behind, we need to take those data and translate them into action. Action for capacity building and continuous quality improvement so that the quality of the data and the knowledge and the interventions is improving, and translating data into action. Advocacy and awareness for generating funds and commitment, governmental and non-governmental commitment, disease prevention, improved use of existing therapy options, and decreased transmission of resistant pathogens. So what needs to be done in the future? We need to identify what actions are needed and what data are needed to support those actions. What data exist? What are their strengths and their weaknesses? What are the information gaps where we need to dedicate some new resources? What partners and skill sets are needed? And what are the costs of action? What are the costs of inaction? At the beginning, the focus was microbiology and laboratory and standards and quality control. And what's been a pleasure is to see growing acceptance by governments in their role in this, by patient advocacy groups, by governmental, non-governmental organizations, and a commitment not only to collect data, but also to utilize the data. So there's been a maturation of an understanding of the role of AMR surveillance in the broader context of understanding and containment.
Now, we've worked through John with the Philippines for the last number of years. And the Philippines have a 30-year AMR surveillance program that looks at phenotypic data across a number of sentinel sites and reports that information upwards through WHO to GLASS on a yearly basis for various bug-drug combinations. So in the Philippines, this project integrated genome sequencing within the routine phenotypic surveillance system, Illumina, data tools that allow the information to come off the sequence and be interpreted locally to identify the strain, which is this operational unit, how similar the genomes are to each other, but also identify the genomic mechanism for AMR and whether that is a particular mutation or whether it's a mobile genetic element that's coming into the country. And because all of this data are digital, it allows that information to be compared, stored locally, but compared to all the global information that's coming. So it gives implications for public health decision-making to help identify potential transmissions at a hospital level, national and international. So we're identifying variants and mechanisms. And this is what the Philippines and Celia Carlos are doing on a routine basis now. They can identify particular clones, and they have been able to identify ongoing transmissions at local hospitals that have led to infection control procedures being put in place to stop the spread of particular pathogens. Now, this is part of a broader project to actually work out what are the key components that would need to integrate genomics into routine national AMR surveillance. So technical support packages around what are the key pieces that need to be implemented around laboratory? So what are the protocols, the sequencing platform, the bioinformatics, how do you rapidly and routinely interpret the data? Data flow, how do you link genomics to epidemiology to really put that context into place? And also other support packages around training, quality assessment, financial capacity building in different institutes. And this is a project that's been ongoing in Colombia, Nigeria, India, and the Philippines that now have functioning sequencing laboratories and bioinformatics and data flow that allows this kind of routine approach to happen. One of the big challenges is ownership of interpretation and ownership of the tools and methodologies. So there are a number of engineering applications and web applications that allow each of the sites to be able to look at the information in a very visual way after processing, to be able to bring that local interpretation to understand what's going on. And each of the countries have produced manuscripts and data and outputs indicate the uses of this information for routine and broader decision making. Now, there are still clearly challenges, and those challenges tend to fall into data and data tools. How do you have standardized information? The routine and rapid linking of genomics to epidemiology, it's all very well having these kind of clusterings, but how do you bring that into context with epi and clinical information and the rapid interpretation? There are a number of emerging data tools that are locally installable, open source software that can be really tailored and owned by local installations. And, you know, I think community of practice around digital epidemiology, community of practice around data engineering, data science, and also software engineering. You know, there's a huge pool of talent across the world that can be brought to bear that we need to actually encourage locally. You know, there are tools that have been developed in high-income countries that are open, that can be used, but you still need that fundamental sort of engineering expertise and the community of practice to be able to deliver that locally. I think our major focus should be on enabling local data generators to have access to the tools and own those tools and interpretation to be able to then leverage feeding into these bigger, broader initiatives. It has to be bottom up and top down.